Wonderful, thank you. I wanted to do something a little more clinical and easy to digest rather than going through like ion transporters on the loop of Henley at 8 o'clock in the morning. I'm sure the rest of the next lecture will be a deep dive using your brain power, so we can do a little more simple. It's probably not going to be a full hour either, but Kings County kidney cases. I found out that this was a renal lecture last week, which was very convenient because both of these cases in this lecture we had last week. So it worked out for us. So quick lecture outline. Kidneys. We had two cases. We have an I can't pee case and an I'm peeing blood case. All right. Chief complaint, I can't pee since yesterday. We have 4 nearly identical vignettes in front of you. All right. And I want you, as I read through these real quick, what is your top 2 differentials for each of these 3 vignettes? Just think about it in your head. All right. We have a 4-day-old male, no wet diaper since yesterday, no fever, cough, URI, vomiting, nothing else. Normal as can be for a 4-day-old, full term NSVD, went home with mom. On your initial exam, normal exam, belly may be a little big, but all baby bellies are big. And if you push on his belly, he's a little fussy, as in all babies will get a little upset when you push on their belly. So not overwhelming exam, and the GU exam is normal. So that's your 4-day-old. Your next patient is a 4-year-old, no urine output since yesterday. Says he wants to pee, but he can't. No fever, cough, URI, vomiting. Some lower abdominal pain, discomfort, but he looks comfortable. And your exam is normal, maybe a little lower abdominal fullness and tenderness if you push hard. No rebound guarding, and his GU exam is normal. You go into the next room. 14-year-old male, no urine output since yesterday. Tries to pee this morning, but can't. No fever, cough, URI, vomiting. Some lower abdominal pain. He's a little active, but no history of positive STI testings that he can let you know, and no current or recent GU symptoms, discharge, dysuria, anything like that. His exam is normal. Maybe his belly's a little bigger than usual, his mom says from the chair. Maybe he's a little tender when you push on his lower abdomen. No rebound or guarding, normal GU exam. All right, so we have 3 identical stories, different age groups. But in my head, I have a number, there's a different number 1 differential for each of these. So just trying to get a little brain working a little bit. All right, so this first case is just general urinary tract obstruction case, how to kind of think yourself through it. UTO is just a blockage of urinary flow anywhere along your urinary tract. It's usually upper versus lower, acute versus chronic, unilateral versus bilateral is your kind of subcategories. In general, it'll manifest as hydronephrosis and with or without bladder distension, depending on where the obstruction is. Obviously, distal to the obstruction will be normal, and proximal will be, distended and have some sort of backflow. Kidney function impairment occurs due to this backflow. It can be reversed if it's relieved early enough, but if uncorrected, it leads to end-stage renal disease. You guys all know this a lot better than I do. General signs and symptoms. The majority of urinary tract obstructions aren't necessarily symptomatic on presentation, especially if they're non-stone obstructions, which stones will obviously give you a lot of pain as a chief complaint. But the rest of the things may not necessarily be evident. They may come in for just not having pee, but not necessarily be bothered or in pain or have symptoms from it. You may have various, urinary symptoms. They're not all asymptomatic, but it's not going to be anything specific. It's going to be just general frequency, urgency, possible hematuria, more ambiguous symptoms. Usually you don't have pain in the bladder from distension until it reaches like 99% distended. So, as your bladder stretches, you're not going to have like pain and discomfort until it's, reached its maximum stretch. And then at that point, you'll have acute onset of lower abdominal pain. But up until that point, it's not going to bother you despite being, sometimes incredibly distended from its normal. So first things in your head, urinary obstruction. quick differential, right? If you have a baby, usually, you can have some sort of congenital obstruction that hasn't been diagnosed yet. The worse the obstruction is, the quicker it's going to present, just because, a kid can only survive so much with, full obstruction renal failure. Posterior urethral valves will go in a little more, but it is the most common cause of chronic kidney disease in kids due to a urinary obstruction. You can have external compression of anywhere along the urinary tract from any intra-abdominal mass, right? Anything that's in the belly can push on other things in the belly. And then infection, inflammation can give you obstruction just from the inflammation can cause swelling of all the different parts of the urinary tract. And sorry, I'm just trying to move things out of the way so I can see. And then that inflammation can just swell, just think croup in the penis. Inflammation can swell and narrow the flow. And then also stone or any sort of other crystalline blockage. Obvious things running through your head when you're first thinking can't pee, urinary obstruction. All right, fast forwarding, what do we see in an ED workup of urinary obstruction? So first sending labs, you're going to see increased creatinine, with the caveat that if you have a unilateral blockage, your kidney function will remain normal for a long time, regardless of how terrible the one kidney is. You can have the one dead kidney and the other one can, for the most part, pick up a full slack. Urinalysis is commonly normal, especially in non-stone blockages, but you can occasionally see blood, white cells, and crystals, depending on the etiology. And then in chronic urinary tract obstructions, as you well know, you can have more chronic issues and you can end up with some hyper K RTA. And then imaging findings, a lot of this is very helpful with bedside ultrasound. You want to see hydronephrosis and hydroureter. And then if the obstruction is distal enough, it will also back up. You can see some dilated bladder, enlarged bladder, all on bedside ultrasound, which you guys are very good at. And then cortical thinning, if some of you are kind of getting used to what the cortex of the kidney looks like on bedside ultrasound, and then you can start to recognize when it is thinner than usual. Again, more adult stuff. I'm sure you're well aware of this, but as it progresses, cortical thinning can indicate level of chronicity of the kidney obstruction, urinary output obstruction. Bedside ultrasound is very helpful. We don't have to wait hours and hours to see if there's some mild hydro anymore. And you can grade them or just a little bit versus a lot. It's clinically not useful to grade it. It's just, is it there or not? And kind of, is it better than it was? But grading it, on scales, everyone tries to calculate things. It's not really clinically useful. If you're concerned about a stone, CT non-contrast. In general, x-rays are not useful at all, other than, they can help identify other intra-abdominal masses. If you have a really large stone, you can occasionally see them, but that's more of an incidental finding. You're not sending anyone for an x-ray for, initial stone eval. All right. I'm not going to go through everything on here, but just kind of another way to visualize a differential of urinary tract obstruction, kind of upper and lower. Upper is considered kidney and ureters, and lower is obviously the rest of it down low. And then the red arrows are kind of just what I thought the more common ones in the PEDS are that you will see. Just kind of review that for a second. All right, and then on the left side, just some quick points to discern. If you have an upper obstruction, you decompress the bladder, you will likely still have persistent hydro because you're still, you only relieve some obstruction, or you relieve the lower obstruction, decompress the bladder. But if you still have persistent hydro after that, you should be very concerned about an upper urinary tract obstruction. And by the same logic, these patients will have a normal post-void residual, but still have hydro on their exam. Conversely, a lower obstruction, you'll always have bilateral hydro because It's, after the two ureters combine, so it'll backflow on both sides, and you will have elevated post-void residuals because the obstruction is distal to the bladder or distal to it. Posterior urethral valves are fairly common. We'll get a couple of these cases a year in general, but some of them will be diagnosed before, and some of them you will diagnose because there's basically there's tissue blocking the urethra right here. If you can see the mouse, kind of at the outlet of the bladder and the bladder neck down here as it goes through the urethra. And usually it's just this, membrane, random extra tissue that just causes that obstruction in that, funneling place as it goes down. Most common etiology of urinary tract obstruction in children, most common cause of chronic kidney disease due to that in children. About a third to half of them are diagnosed prenatally on ultrasound if they get prenatal ultrasounds, because you'll see the kind of triad of that is bilateral hydronephrosis, a dilated bladder, and a dilated posterior urethra, which is called keyhole sign. And I will have a picture of that so you can look for it on your bladder ultrasounds going forward. If it is severe obstruction and it is not treated, it can progress. The progression of it, especially intrauterine, is you have you will have oligohydramnios because you will have decreased urine output, so you will have decreased amniotic fluid in the sac. And then secondary to oligohydramnios is you'll get lung hypoplasia. So if it's that bad and uncorrected at birth, you will have lung hypoplasia and have chronic lung issues for the rest of your life. If it's incredibly severe, they do have fetal surgeries for it, but for the most part, it's something that they will watch on prenatal ultrasounds and correct as soon as they're born. But if it's not a full obstruction, then you won't have all those findings on the prenatal ultrasound. You won't necessarily have, complete, lack of urine when you're born. So some of these partial cases can have delayed diagnosis. So your neonatal symptoms will be respiratory distress and abdominal distension at birth. This is more kind of those undiagnosed lung hypoplasia patients. And they'll have the respiratory distress from the hypoplasia and the abdominal distension, obviously, just from the full hydro and distended bladder. If they survive the neonatal stage, as infants, they'll present with frequent UTIs, failure to thrive just due to, general chronic medical issues, urosepsis from UTIs plus the obstruction and bladder stasis and hydro. They can also, parents can report just straining with voiding, grunting with voiding if it's just a partial obstruction that just needs some extra Valsalva pressure to get past. And then if they make it a little older, you'll run into kind of incontinence, nighttime bedwetting, UTI, frequency, urgency, poor or weak or splayed urinary stream, something like that. And those are obviously going to be more partial obstructions if they survive undiagnosed to the toddler stage. Treatment for this is, basically you take a scope, you go in and you just ablate the extra tissue and your problem is solved. So this is kind of a little side view. You have the bladder, you have the neck out here, and this is where most commonly the extra membrane will be. And you can see sometimes it will just completely ablate it, but lots of times it'll just kind of be the flap and cause this almost complete or partial obstruction. On the bedside ultrasound or formal ultrasound, this is what the keyhole sign is. You have the bladder, and then this is just like the very first part of the proximal urethra here. You'll have the obstruction. You'll see this kind of distension here, which is what this keyhole is. If you're putting a key in a lock, and that's just the little keyhole part, and that's the rest of the bladder. So yeah, if you ever see that in the setting, it works. All right. Quick slide on kidney stones. We are seeing them more and more in children. No one knows why. It's probably a combination of increased obesity, no one drinks water anymore, and our diet with lots of non-natural stuff and crystal formation and solutes and chemicals. No gender predominance seen in children. I think there's, slight gender disparities in adults, but in children, they found there's not really much of a difference. The biggest risk factors for kidney stones in children are just structural anatomic abnormalities that will prone you to urinary stasis or turbulent flow, infection, obviously urinary tract infections. Of the infected children with infection causing stones, the majority of which are males. And real quick micro, the bacteria that will cause your UTIs produce urease, who will then down the chemical line produce struvite stones. Those are those staghorn calculi in the kidney that have those fun pictures that you study for in step 1. And the third big risk factor for kidney stones is just any sort of metabolic abnormality, either excessive solute production, calcium oxalate uric, or decreased inhibition of stone formation. So if you have any decreased citrate, diseases, magnesium pyrophosphate are the things that fight to prevent stones. So if you don't have that, you'll have increased stone formation. Usually some sort of citrate deficiency is the most common reason of the decreased inhibition. But there's not a whole lot of data in children for anything, but in 2 case studies of pediatric stones with several hundred children, they found like 90% of children with stones had at least one metabolic risk factor. So this goes to show that the anatomic stuff will get caught early for the most part before you progress to stone formation. Infections are infections, but not a whole lot of them will produce stones in pediatrics. The majority of these are going to be kids with some sort of metabolic issue, just to have on your radar. Other less common risk factors, not so much for children, but maybe the adolescents. High protein diet, gains, ketogenic diet, so hot right now. And then there's some medications that can predispose you to having excessive solute excretion or decreased inhibition, and I'm not going to go over them. Also, cystic fibrosis can give you an increased risk of stones. No one drinks anymore. Hydration. My college roommate just had a kidney stone because all he does is eat protein powder and never drinks water. That'll give you stones. No one drinks water anymore. All right, real quick. It's not a stone lecture, but we see it a bunch. I've probably had 3 or 4 kids with stones this year, up from not seeing them younger. Everyone sends a UA. Examine the sediment, wait for the micro, look for how many actual cells, look for their description of the crystals or the sediments in there. Ultrasound to see if there's any signs of obstruction from the stone, or CT non-contrast is your kind of gold standard for stone identification, even in children. And then management-wise, you either have to go in and get it or you don't. Majority of stones less than 5 millimeters is kind of your size cutoff. Give them pain control, lots of hydration. If they can orally hydrate, that's great. If they can't, put them on OBS. Antibiotics, if there's a UTI, you don't need to empirically antibiotics these kids unless there's a reason to, if they're like a solitary kidney or something. And then kids can get Flomax as long as they're 2 years old. And I know the data on Flomax isn't big, but the recommendations are, it'll probably help a little bit. It'll be fine. Might as well try it. And then if you can't pass a stone on medical management in a month, if you have a complete obstruction, if you have a single kidney with the stone with signs of an infection, or if you have severe symptoms that you're not able to be discharged on, you will have urological intervention for various things. They'll laser them, they'll blast them with sound waves, they can scope them, put a stent in, all sorts of urology stuff. I know I love these cartoons, but they have the gallbladder one that was famous, but I did find the kidney stone one. All right. The important stuff. What do we do about it? Okay. If you have an upper urinary tract obstruction in the kidneys or the ureters, we're going to call urology and they will take care of it, right? We're not putting stents in or percutaneous tubes in the ER. They're going to the OR. End of story. Lower urinary tract obstruction, decompress the bladder is the first step. You can do that with the Foley. You can do that with the little feeding tube, the 8 French, 5 French feeding tubes that we use for urine caths. They don't have to be an indwelling Foley. You can do intermittent catheterization if you just need to decompress the bladder and then, we'll start fresh. You can just do feeding tube cath and then take it out and then, keep going. How urgently do you have to stop the obstruction? It is an emergency, meaning you have to decompress, you have to fix the obstruction within several hours if there's urosepsis or there's severe metabolic, hyper K, things like that. Otherwise, it's just an urgency. You have 24 hours if it's just an acute kidney injury or if you have a complete obstruction bilaterally or a single complete obstruction, they'll still give you up to 24 hours. Please do not talk. It will still give you up to 24 hours completely obstructed before they will go in and do it. Seems like a long time to me. And then obviously I just needed a picture. So that's how you put a Foley in. Okay. What do we do in the ER? A little more stuff. Confirm adequate hydration. A lot of times they'll come in and, oh, my kid hasn't peed in a day and the bladder's not overly distended. And it's like, well, let's just push it a little more, give them, IV fluid bolus and then see, what the bladder size is. A lot of times it's just, a little inadequate hydration that will do it and the problem will fix itself. But if they are having distended bladder with urinary obstruction, put a Foley in versus a feeding tube. Now, they prefer intermittent catheterization at first rather than putting an indwelling Foley, mostly due to infection risk, but mostly due to once you have the Foley in, you then have to take it out and prove yourself. If you intermittent catheterization, you catheter, you decompress the bladder, and then you take the catheter out and you're already to the point of, proving that the patient can spontaneously urinate, which you need to do prior to discharge. It's helpful with bedside ultrasound to compare bladder size and level of hydro before and after decompressing the bladder. And then you also obviously want the patient to void spontaneously prior to going home, decompress bladder, feeling comfortable, urine studies cooking, saved a life. So here we have, we can't Foley, can't catheter, suprapubic catheterization, very scary. I did it once in fellowship. It was a male with just, you couldn't pass the urethra. So, whether we are unable to find the urethra, unable to pass the catheter, you can't get the Foley in, how do you get the urine out? It's a intimidating procedure, but it's actually super simple and super easy with, the only complication is that you perfor bowel, but especially if you use ultrasound, just make sure there's no bowel over the bladder. It's actually much, much, much easier and less, more foolproof with the ultrasound because you can just see skin, galea, bladder, put the needle in, Seldinger technique, and take the urine out for studies. If you want to do an indwelling suprapubic catheter, you can just use your central line kit. You can use a butterfly if the baby's, young enough. And that's how you do it. So our baby, back to our patient that started this case. So there's 4-year-old female, no urine output since midnight the day before. She did the right thing. Her parents brought her to the E building clinic. My baby hasn't peed since midnight. Doctor in the E building immediately told them to go to the ED. Did nothing. So no other symptoms. Just woke up, can't pee. She said, oh, my belly hurts a little. Mom said, I think the urine smelled funky. On chart review, because I did my care everywhere. 3 months ago, she went to urgent care. She had the complaint that she needed to urinate, but couldn't. And the mom's like, yeah, she felt warm, but there's no measured fevers, no other symptoms. And the fast track urgent care doc just put urgency, from that history. They were unable to obtain a urine sample as the patient couldn't pee at the time. Obviously, no one's cathing children in urgent care, so they just kind of shrugged their shoulders and moved on with their life. The diagnosis was symptoms of a UTI. No testing sent, got 5 days of Ketflex. Who knows? Clearly, she wasn't obstructed for a long time, but she went to her PCP a week later and she said, I took the antibiotics, it got better, everything's fine, and no one thought about it again until she came last week to the ER. So on her initial exam with the resident, there was some bladder distension, there was mild hydro seen bilaterally. And then after talking about it, the resident thought that she saw what looked like a prostate behind the bladder, which was a little interesting. Quick anatomy. All right. Our bladder is conveniently highlighted for you by the people who made this picture. So females, what's behind? Our uterus not going to be predominant in a 4-year-old female. It's going to be a little higher. Males can have the same thing. We're thinking external compression of the bladder outlets. What could possibly be in the way here? What is my favorite diagnosis? So from looking at this kid's triage, I was just waiting for the question to be asked. And of course, I asked if there was constipation, and mom said no. Is the silliest question you guys ask. Is there constipation? The answer is always going to be no, unless they have a medical diagnosis and follow up with GI. The follow-up question would be, are there soft daily stools? Does it hurt? Bristol stool scale, have it on your phone. Because the answer is always yes. The same thing is, are your kids' vaccines up to date? And the answer is yes. And my question is, how does the parent know? You don't even know the vaccine schedule. The parent certainly doesn't. So unless they're anti-vaccine, they're just going to assume that the pediatrician is taking care of it. So you then have to follow up and, get the answers yourself. So they'll always say there's no constipation, but we do see quite frequently that one of the external compressions that can cause some bladder outlet obstruction is just an incredible amount of stool behind the bladder pushing and obstructing kind of this. You can actually see it because that bladder outlet is a little inferior posterior, and there's just all this stool pushing in. It'll kind of choke it off right there. And it can cause urinary stasis, and we do see UTIs from constipation, even if there's not full obstruction, just because it's a little partial obstruction. It'll give you enough stasis that, something will start cooking in the bladder. All right. Our patient's story, we went back, asked some clarifying questions that revealed there was some non-daily painful stoolings. Conveniently, after the bedside ultrasound, the patient spontaneously voided on her own, probably just from the pressure of the ultrasound probe on the bladder was enough to overcome the pressure from the poop squeezing her urethra closed. So she was in a bag prior from triage, unfortunately, but the bag urine was sent. I did start empiric Keflex because there was the question of that 3 months ago was a real UTI or not. And if you're in lieu, no one's going to be harmed by some empiric Keflex in this situation. Because we didn't wait for the UA, it was the beginning of a 3 to 11 shift. It was very busy, shared decision making. She looked great. Ideally, we would have waited for the UA to come back, waited for a second spontaneous void because this first one might have been a little kind of pushing on the bladder and not 100% spontaneous. But kid looked great, parent was reliable, and we sent them home bouncing and happily walking out of the emergency room. And then the UA did come back completely negative, no culture sent because it was a bag specimen, and she has follow up the PCP. All right. Any questions on that case while that's fresh in your mind, or I can move on to the next one? Also, if you see something weird on your ultrasound, please verbalize it. We won't make fun of you because that prostate behind the bladder on the female was just a large stool. But see something, say something. All right. This is a shorter one, but I also had a case of one of these last week. So I'm peeing blood. We see this a lot. Lots of things make the urine red. So step one of all of these is to confirm that it is in fact blood. Same thing with I'm pooping blood. Confirm that it's blood. Lots of things make poop red. Lots of things make urine red. Okay. You can have dipstick positive, can be blood, free hemoglobin, or free myoglobin. You need the micro to determine whether it's actual RBCs or just the globins floating around. 1 ml of blood in 1 liter of urine can cause a color change. So degree of color change of the urine, how red it is not helpful at all. It's a very binary thing. There's blood in it or there's not blood in it, just from visualization. Quick list on the right side is all the medications, dyes, or other things that can cause red urine that is not blood. And that is an incomplete medication list because Omnicef, for example, can cause orange urine, which can be confused with blood urine. We see a lot of food dyes, or both the natural food dyes and artificial food dyes that give you cancer. Well, a lot of them will trickle down and color the urine. Alrighty. Okay. Gross hematuria, and gross just means that you can see it visually, the color change, rather than only seeing it on micro. Most common identified causes in pediatrics are urinary tract obstruction, any trauma, both to the GU system or intra-abdominal trauma, blunt kidney trauma can cause this, or just any inflammation, abrasion to the urethral meatal opening. We commonly see in the little boys who can't keep their hands to themselves. Other differentials, less commonly, stones, sickle cell disease, any coagulopathy, any glomerulonephritis, nephrosis, nephropathies, or malignancies can give you hematuria. Again, no one does great studies on children, but there was a 10-year retrospective review of about 350 kids who presented to an ER with hematuria, and roughly the etiologies were kind of 1/3, 1/3, 1/3. 1/3 nephritis, nephrosis, glomerulus, 1/3 non-glomerular cause, stone, UTI, coagulopathy, something like that, and 1/3 never figured it out, went away on its own. We don't know what caused it. Benign isolated hematuria is very, 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 very common, especially in boys. We will discuss it later. But there is also urethroragia, which is just post-micturition bleeding that can seen in adolescent males. You will pee, have a completely normal urine stream, and then just a couple drops of bright red blood will come out after the urine stream ends. No one knows why it happens. It's benign. It goes away on its own. So, you kind of keep that in mind with, these adolescents present to you, you do your, workup, you send a UA, and if everything's fine, it'll probably be fine because there is this benign, post-urination bleeding that can be seen in adolescent males. I just thought this picture was fun and old-timey and is actually fairly complete as to hematuria, but I don't need you to read it. But general questions you want to ask on history when you have a hematuria patient: how long has it been going on? Did you have, sudden new onset symptoms, acute suddenly that would indicate a stone or UTI, or has it been something that's been happening more insidiously? Any recent trauma, any recent vigorous exercise can give you free myoglobin in the urine and give you red urine. Are you having unilateral flank pain? That can, kind of trigger you off down a differential. What exact color is it? Are there clots in the urine versus no clots and just blood? Any recent illnesses, medication exposures, and also when does the blood happen in the stream? This can be useful information that I find that the residents often don't get on history their first pass. It's a helpful question to ask them. If you have initial hematuria, the blood at the beginning of the stream, and then it clears, it's most likely a very distal injury or urethral source of the bleeding. If you have terminal hematuria, only, it starts clear and then it gets red, it is most likely a bladder source. If you have continuous hematuria, it could be anywhere, and that is unhelpful. But if there's any changing of color during the stream, that can help discern location of the source. General physical exam: blood pressure. You can have low pressure from exsanguination if there's a trauma, but otherwise you'll have high blood pressure from glomerular disease. With that, is there any recent weight gain or edema? You have growth charts on everybody. Please look at them. Any rashes, lupus can cause kidney disease, and you can have malar rash versus other cutaneous symptoms. All right. Are there palpable purpura on the legs? All right. HSP can give you hematuria. So, but you have to do that lower extremity exam in order to find the skin findings. And obviously you examine the genitals. Okay. I've had residents come to me with hematuria patients and they did not examine the genitals. Not sure how that happens, but it's something that needs to happen. Look at where the pee comes out to see if there's blood. All right. Because commonly, especially on the toddlers, elementary school age children, they get bored and their hands are constantly down their pants and you can just rub. Even the diaper age kids, just rubbing and you can just, cause distal abrasions on the diaper or the underwear or things like that. Sometimes you can't see them, but they will, if you get a history of like it hurts right there when I pee, and they'll point to the urethral opening, even if you don't see obvious trauma, it's usually what the etiology is if everything else is negative. Obviously, abdominal exam for any masses or tumors. It's something you don't want to miss because we will find them. Parents don't always feel on the bellies. Pediatricians don't consistently feel on the bellies. So we are, we in our ER have found Wilms tumors and belly masses before just because, we were the most recent one to actually do a real abdominal exam. And I always thought this is helpful. This is from up to date, just kind of distinguishing glomerulus versus non-glomerulus. Glomerular injuries are usually more of the smoky brownish Coca-Cola urine rather than pure red, but not always. If you have clots, that is most likely post-glomerular. Glomerular will have protein leaking, so you have proteinuria. It's almost always present. But if you have a stone or some sort of bladder issue, you can have protein. If you have protein, it's usually a significantly less amount, like a trace or a 1+. You're not going to have like 3 or 4+. And then you'll have cast on the glomerular side and not on the extraglomerular side. I always pull it up. But it basically take home points. When do you have to care about it, right? This is what the one slide you want to pay attention to, okay? If you have asymptomatic isolated hematuria, no symptoms, no fevers, no pain, no protein on the urine or trace protein and just blood, then it'll probably be fine. And they can follow up with their primary care doctor in 2 weeks for a repeat UA. And if their repeat UA at 2 weeks has persistent hematuria, then they can, start this workup below and get referred to renal for biopsies and whatnot. Okay. If you have symptomatic hematuria, find the cause of the symptoms and treat it. All right. Is it a stone? Is it a mass? Is there something causing severe belly pain that you can't figure out? You either figure it out. If you can't figure it out, get your consultants and admit to pediatrics. That's what they're there for. All right. But if you're having symptoms, you got to fix the symptoms. If you're not having symptoms and it's only blood, it'll be fine. If you have protein in the urine, you have to care about it a little bit. Okay. So initially, you don't have to do a renal consultant's job in the ER. A lot of the stuff that they want is not going to come back in a timely manner. This stuff mostly comes back in a timely manner. This is the stuff that we will send to kind of start the process as we refer them back to their primary care or their renal. All right. Urinalysis, obviously, urine protein creatinine. This is just a random spot ratio that renal will ask for, and it can be helpful. Ideally, you want a first morning urine protein creatinine ratio and or a 24-hour urine protein creatinine, but that is renal's job. They will take care of that. But if you can think just to get a spot random protein creatinine ratio on the next time they pee, if you find, significant proteinuria, that would be very helpful. And then quick blood draw. You want to comp mostly just BU and creatinine and albumin levels, and CBC mostly for infections, some sort of chronic disease, cancer screening, any signs of anemia, things like that. And then ASO to screen for recent strep infections for post-strep glomerulonephritis, and then C3, C4 complements. That's it. That's as deep as kind of we want to go. If we commonly, for the significant proteinuria patients, we will commonly call renal. We have renal fellows that are happy to answer your questions. But for the most part, this is all they care about in the ER as well. They may, occasionally add on a couple things. So it's good to, loop them in. We don't consult them that frequently and bother them. So if you have a renal patient, please feel free to call them. But in general, this is a great start for an ED renal workup. Any questions or comments about that? All right.
Question, the ASO comes back really quickly.
Yeah.
Thanks.
Quick question. What is your threshold for getting a CAT scan to evaluate for kidney stone in children?
Pretty low. I'm trying to think, like, I can't recall that I've had a kidney stone kid less than 10 where I would kind of hedge on it. But I mean, adolescents, if you're concerned for a stone, just scan them. As much as the PEDS people hem and haw about radiation, I mean, all of our patients fly like 5 times a year and get an incredible amount of radiation. So if you're concerned for a stone, feel free to scan them. Don't let the radiation threat scare you away from finding the stone if you have a medium or high suspicion for it. And with that said, if you have a little kid, it's something to talk about. I haven't had it personally, but if you have a 5-year-old and he has hematuria and he's in pain and you're concerned for a stone, you should probably go ahead and scan that kid too. All right. Last slide, and then you can have a couple minutes before your tox lecture, which will cause you need some brain power for that. My kids are starting to die too. All right, nutcracker syndrome. Think of it as SMA syndrome on the renal vein. Same pathology. It's actually the same 2 arteries that do the squeezing. It's the aorta and the proximal superior mesenteric artery. And that left renal vein runs right in between them. And if you're unlucky, super skinny, have a tight junction, I think it's something to do with how, like, the angle of how the SMA comes off the aorta. But you can squeeze that left renal vein, cause backflow into the kidney, and you get what's called nutcracker syndrome, and you'll have intermittent asymptomatic hematuria. This is why, even if we send them home, they have to repeat the urine to make sure it's not persistent or intermittently persistent. But intermittent asymptomatic hematuria, it's always on the left. About 20% they've found will complain or report some left flank pain, but most of them will not have any pain. Again, on a good physical exam, about 1/3 of these patients had left-sided varicocele on their exam, but you only find it if you look for it. And this can give you just, if this progresses and the severity of obstruction is bad enough, you can have some more chronic kidney issues, but it's mostly just identification of the source of intermittent hematuria. And your management for it is just weight gain. So you have more intra-abdominal fat so that the vessels aren't squeezing as much. You basically have more fluff to give the vessels space. There you go. Dr. Khan found a kidney stone on an 18-month-old with a big bladder getting an intussusception workup. So there you go. It happens to all ages, especially, we have lots of kids with, kind of low-level metabolic issues, various other issues for high solutes, low hydration. But that is it. Actually took most of the hour. Didn't want to go too deep on you. My sources, up-to-date Cleveland Clinic for pictures, AAP, most of it is up to date. And then these are Iceland pictures from the summer. So if you haven't been to Iceland yet or heard me talk about it relentlessly, go to Iceland. It's amazing. But that's all I got. Let me know if you have any questions about anything. But yeah, I had both of these cases last week, conveniently.